Hello, welcome and kumusta? Thank you for joining me today. This is How. I am your occupational therapist. And in this episode, I have a guest OT apprentice with me today.
Hello.
Hello, Grace. Welcome, Grace. And thank you for joining me. So, Grace has been working with me in critical care, and we have an opportunity to explore her experience. She might have some questions for me. So, we don't know. We're going to be surprised. So, how are you, Grace?
I'm good. It's my last week this week.
That's good.
Critical care.
Critical care. So, I'm going to be asking you questions then.
Mm-hmm.
How did you find the experience?
It's been more than I ever expected, really. It's in like a really good way. I think I've learned a huge amount. And it's been really unexpected because I'm an apprentice, I work in a district general hospital and I'm used to sort of working in quite a different way. And I thought the two settings would be quite similar, both sort of acute inpatient hospitals, and I didn't realise it would be quite so different.
Okay, you say it was a bit different. What is it that you like the most out of the experience?
I think the freedom. I think the fact that I've been able to meet patients and kind of use my own initiative and understanding of them to do OT with them in a kind of very holistic, traditional OT way. I think I'm used to working in quite a prescriptive, kind of structured, assessment-focused, discharge planning way. And critical care has just meant I can go in and actually do something that's person-specific and meaningful and like really, truly occupational focused.
Right, so that's a little bit strange for me, Grace. You say freedom. There is freedom to do some things in critical care? Yeah, how are you free to do something?
I think because actually they're patients that you're not discharging them, you're not kind of looking at those like really goal-centred, kind of very like functional in terms of like ADLs and washing and dressing and those kind of like very discharge planning focused things. You're actually looking at like a really broad scope of occupations because they're patients that aren't moving anywhere particularly quickly and they're not going to be sort of doing anything more than what they can do sat up in bed. And although that is a restriction, you've then got loads of options. You can do whatever they want to do within that.
Within that boundary.
Mm-hmm.
That's amazing, isn't it?
Mm-hmm.
So as you were saying, so we were talking about critical care, yeah? And critical care, as you did mention, the person is attached to lots of things, lots of life-saving devices, perhaps ventilator, maybe lots of lines attached to them. And despite that, what's interesting is you still find that you've had a lot of freedom to work with patients, regardless of them being confined. And wow, I'd like to explore more on that, really. So how did you say you're more free when the patient is really confined?
I think because like I'm used to working in the problem is already predefined in the way I'm used to working. So I've got background in stroke and also in surgery and oncology, and you're going there and you know the goal is to get them out of hospital and discharged as soon as possible. And so you're then working very specifically towards that goal, and all your assessments are sort of predetermined, and you're doing a functional assessment to see how well they can get out of bed because you need to get them home to their bed at home as soon as possible. But on critical care, you haven't really got any of those predefined aims and goals or anything like that. You're just, okay, what can we do with this patient? Because they're not engaging in any occupations at that point. They're often sat in bed for several months at a time and they're not doing anything, and therefore kind of anything's a bonus. And anything you can engage them in is a huge win. And that within that there's a huge amount of freedom. You're not like what you're aiming to do with them isn't really predetermined.
You're right. That's amazing, isn't it?
Mm-hmm.
Wow. You know what? We've been working for a few weeks and it never crossed my mind that is how it would have it would come across to you, regardless. You're right, you're probably right. When you go into a hospital, in a district general hospital, or you go into wards, there are some preset targets already, isn't it? To get them out and to get the patient moving. You need them to be independent with their functional mobility, to be independent with their toilet hygiene. There are some tasks, almost criteria or categories or target performances that they need to do, that I think for a starting clinician, that's exciting. But after a while, it becomes almost prescriptive, isn't it?
Absolutely, yeah.
Yeah. And then now you go in critical care and all of a sudden you cannot do washing and dressing, or you're limited with functional mobility. And then you're there faced with a patient or a client not knowing what to do and just exploring what the problems are, and then having that option to do some things in the confines of the bed, or in the confines of them being on the chair, or in the confines of those attachments.
But that's when you can be creative,
Wow.
because if you're working within the limitations, but you can think around that problem, and that's what that's one of our skills, I guess, is.
You're right, that's good. I like that thought, to be creative. And it's not easy, isn't it? It's not easy to be
No.
creative. It's not easy to think of some things very quickly. So that's why I think, OT should be funded and have higher banding, because, it's a psychology. You got to be quick in thinking about things and what are the things. And it's not just being creative, because when you're being creative, it means that it's coming from the therapist itself. But this time around, you have to factor in what the patient's got to say. What are the things that you would consider in a patient?
I mean, you'd be considering their sort of interests in general, so things that, naturally that before they were admitted had an interest in. There's no good trying to sort of foist an activity on someone that they're not going to be interested in at all. But you're also considering like what's appropriate in terms of their fatigue levels and how unwell they are, and the attachments. And so, we normally, when we've been seeing patients, we go in and we see their upper limb function and actually see whether or not they can, can they lift something up, can they engage, what's their kind of grading level of what activity we can sort of prescribe them. And just also see their level of engagement and motivation, because a lot of the patients we've been seeing have been on critical care a really long time. And actually they might be sort of sick to the back teeth of people coming in and annoying them, and they're really not feeling very well, and they're just not very engaged. And so then you'd sort of change your approach with them based on that as well.
Okay. And do you think occupational therapy has a role in critical care?
Absolutely, yeah, absolutely.
Yeah.
I think in a kind of quite practical sense, and we've seen quite a lot of stroke patients, and that's kind of doing stroke initial assessments is sort of one of the sort of fairly more standard.
That's easy, straightforward,
easy
yeah.
and straightforward. But also, like, we've seen so many patients where there's been that kind of slightly indefinable OT magic.
Wow.
That kind of thing you can't quite explain to someone who hasn't seen it, but
it's there.
It's there,
It's there.
And that it's been such a surprise to me coming into what in some ways would be like the most acute setting that you can find yourself in, and actually finding that it's a strangely really like fertile breeding ground for that. It's a really interesting like dichotomy between the two things.
Wow. I just got goosebumps when you were saying these things, isn't it? This is amazing, guys. Wow. Wow. I'm almost speechless, because, there is something there. There is something in the person that calls for occupation. There's something in the person that calls for occupational engagement. Yeah. For those of you who are following these podcasts, I've got some podcast topic about OT in critical care. And it's one of the programs in there is this thing which I named Active OT program, or Activity program, where the topic or where the objective is to provide some activity, and the treatment, the occupational therapy is occupational therapy, isn't it? In the pure sense of occupational engagement, purposeful therapeutic activities and person specific, interest specific activities. And you can never lose, isn't it? Anything you do will just fit into that.
I mean, particularly when you're, to put it in context, if you've got a patient that might be waiting for a heart transplant and is very unwell and they're on critical care for months, sort of waiting indefinitely with no kind of definite date for when they're going to receive their organ. And they're so unwell, they're really, like, they're bedbound, they're full assistance for all their ADLs, they're really, like, they are not really able to engage in anything at all. And so anything that you do is a bonus, and it's that kind of, it's just that need that people have to be engaged that we get to work with in this environment, which is really exciting.
Very exciting indeed. Wow. Okay, well, that's strange because I thought you were the one that was going to ask me questions. So in the end, I was the one that ended up asking you lots of questions because you're working. Grace is an OT student and she's an apprentice, and this is her placement, and she's learning to be an occupational therapist, and so she's read about occupational therapy. The occupational therapy is being taught, obviously, in the university, but I think there was an opportunity, and there has been opportunity for her to really see it in action, where you are not really bounded by the pragmatic challenges of discharge planning. And we're still confined by the context of the illness and the physical disability because of their medical situation, but you get to think about occupation. And I think that's really nice. And I'm really proud as well, because hearing you talk about this, it feels like, I'm talking to a lecturer and I'm learning something, which is really good. I'm listening to you with fresh ears, really, not fresh eyes. I listen with fresh ears. Yeah, and I'm looking at it with fresh eyes, isn't it? Wow, high-level English. This is how with high-level English. Cool. Do you have any questions for me or things you want to clarify, or you put me on the spot? Put how in the spot. This is now a section called Put How in the Spot.
I suppose because initially when I was put down to go and do placement here, the plan was originally for me to be on a more general ward.
Mm-hmm.
And then I think in the first week we changed to putting me on critical care.
Mm-hmm.
And I suppose at that point I didn't really understand why, because obviously I didn't really know anything about critical care or the general ward. And I know that you kind of assessed me almost and decided to put me on critical care, which is the first time there's ever been a student on critical care in this hospital. And I suppose I'm curious as to what you think the qualities are that you need to be on critical care, or kind of why you thought I could do it, because I didn't know I could do it.
You're right. Well, I'm an occupational therapist for quite some time now. Many years. I think even before you were born, Grace. But I think one of the skills of occupational therapy, like myself, is this thing, activity analysis. Over a period of time, what occupational therapist tends to do, and you develop this skill, and eventually you will develop this too, you will have a quick gauge of the person and the person's abilities, and you will have a quick gauge of the challenges that they need. And I don't know how I managed to do that, but it happens very, very quickly. When I'm asking questions about how things are or what your interests are, for some reason, I'm also analyzing your answers and having a quick gauge on that. So I know for a fact that you have worked in the hospital. And so it's just like treating you like a patient, isn't it? Or a client, isn't it? I know for a fact that you have worked in a hospital. I know that you've had a good experience with stroke and neurology. You've worked in a stroke ward before. And I think if we bring it more on a superficial level, having that skill of neurology, of moving and handling, those are the two things that I would feel be very, very beneficial for an occupational therapist to work in critical care. And because you've worked in general surgical ward, that's fine. So I'm happy that that you will not be threatened by what looks like very, very frail and very sick patients. So I can gauge that. And I know that you can understand neurology as well. With neurology and neurological cases, you see the person holistically. Yeah. So you can see their functional communication, their cognition, their movement, their emotion, and their mood. So knowing that a person has had an experience with stroke and neurology, I know that you can see and look into the person as a whole, rather than just a person with a fractured hip that they can't do some things. It's very much more holistic. So that's one factor that I considered. The other thing as well is, again, I know that you've worked in a district general hospital already, which means that discharge planning will just be very easy for you. And initially, I thought of putting you in a cardiology ward, but I looked at the challenge. It would have been so easy, for you. It would have been so.
And that was what I was expecting.
Yeah.
Because I was expecting to sort of it to be very similar, and I was worried I would be a bit bored.
Would you? Oh, I thought I was expecting that it would be easy.
I think because I'd also had the experience before coming to placement of covering a ward by myself, and so actually I had done a lot of discharge planning and
Yeah.
that kind of like
Yeah.
sort of setting and decision making, I suppose.
Okay. So those are the few things. Generally, the challenge that you needed is that I know that your experience, the ward is already there, and I think this is from my experience. If all the OT apprentices are going to be like you, just gonna be like Grace, it would have been a wonderful placement. It would have been wonderful for all the services who would be receiving an OT apprentice as an OT student, because you don't have to start from scratch. You already have the foundation experience. All I needed to do was put labels in what you were doing. So all I needed to do was to supplement you with the models of practice, what else? The continuum of care. Why we're doing things. What are the historical? The historical Brunstroms and Bobafs and Roods and all of these things, and the history and the story behind the documentation. So I just needed to put that into context, or put labels really on what you know. So again, are there any other things? I mean, pragmatically, when you started, and I'd like to share it to my listeners out there, it's not just Grace who's my student. I attempted to have 2 students at a time, but both students have different strengths and different needs. Both are coming from different universities, and they have different needs. So, and I didn't have planned for my other student. I didn't have planned for you, But it's, again, I came in, and the students came in, and within the first week, I have been trying to gauge what was the best place. If I didn't have any option and I didn't have any choice, then we will be stuck in cardiology. You will be there. But we'll make it as exciting as your experience in critical care. But yeah, I think it's the experience in neurology. I know your strengths and I know what you would need. And that was a quick analysis from one occupational therapist. And this is not analyzing a patient, but analyzing another colleague, potential colleague, future colleague, and another individual. Yeah.
Because I guess I had to trust your judgment.
Yeah.
With like my,
I know.
I had to trust that you could, see what I could do. And
Was that scary?
A little bit.
Was it?
You know, the idea of being on critical care it was like, it was quite unexpected, and also it was. I remember the first day or two, I think you sort of let me loose on the ward, and the phrase you used was go and swim up the ward.
Exactly.
Go and talk to people.
Yeah.
And I ended up sort of talking to some patients and some things, and then I sort of reported back to you, and you were like, that was more than I expected. And I was like, really? Because I think I'm used to sort of being quite under pressure, and so you have to go and see patients.
Yeah.
And being surprised I could do it almost.
Yeah, and I think for a placement, I mean, you're a student at the end of the day, and as student, regardless of which university you're coming from, I'm teaching you the basic things, how to work with patients, how to find out problems, how to plan to resolve those problems. So the first few days, wow, that's what I said. I almost forgot about that which is true. You know, go as long as rule number 1, and this is from me, and this is from How's experience in another country. Just don't kill anybody, isn't it? That's the number 1 rule. Don't pull things. If you don't know what they are, step back. It's all right. But I ask you to go and get familiar with the place. Be curious, isn't it? It's just like a kid, going into, there is this jungle, there's this woodland, only with bleeping respirators and monitors. It's like, ooh, what's in here? Can I come in here? If you go into the woods, what would you do? Ooh, where would you hide? Where can I hide? Where can I set up camp? Isn't it? Which tree can I climb up? I'm gonna perch on that tree. That's gonna be my home base. Where can I put my hammock in?
I mean, there aren't any hammocks in critical care.
There wouldn't be, but there are some slings, but you've not seen them. I don't think we have hoisted somebody in a bed.
I have with physio.
Oh yes, you have been. You've tried that with physio, yeah. Oh yes, okay. Well, I wasn't there. Yeah, for the record, Grace managed to see it, but that's good. Any other questions?
I suppose the main question is, because the thing I've sort of been aware of on critical care is actually there's a little bit of a divide, or a sort of sense of it being quite a new space for OT to be in this hospital. And I was also very aware that you were kind of trusting me with that, because it's the first time I've ever had a student on there, and normally it's just you working on that ward, and the staff kind of got to know you, and that's fine. But then bringing someone new in, who is a student and therefore kind of slightly unproven, was a bit of a risk. And I was very aware the whole time of like trying to maintain a sense of professionalism and really trying to represent OT well. And I suppose that my question is, like, was it a help to have a student, or was it a hindrance, or were you aware of that?
Well, it definitely is a help, because one, students are so willing to learn. Yeah, that is so nice. And everything, I think as a student, maybe not as a young clinician, students would have this eye of that opens up to being at awe, the eyes of wonderment, isn't it? So as a student, I know that when you're there, you can either be scared of it, or you can look at it with awe, because you are learning so much, isn't it? And for that purpose, I think that's a help. The other thing as well is that I wouldn't be in any pressure. We will not be in any pressure, because if it was a clinician who's there, who has the half of responsibility, or half the responsibility of looking after a ward, we know that people will gravitate towards the ward, because what is there to do in critical care is always the big question, isn't it? So having a student is good. I mean, to be fair and to be honest with you, this is also a trial and an experiment for me. If it failed, then I might not do it ever again. But I think now, based on this experience, and I know how to go about with things, I have already a set program for whoever is going to be lucky to try critical care again, if I allow them to go to critical care, and should I have the will to do it? It's really nice though. So as a student, did it help? Yes, it did help. Again, it's not just you; it's your strengths. It didn't matter to me whether you're a student or whether you're a clinician. At the end of the day, did I feel you have the ability to do that? And it felt like you did. And I also know about your interest, Grace. I know that you are interested in art as well, or has a history of previous profession being in the field of art. So creative side of things is always important for occupational therapists. So I know that you've got that in your tool. As a student during my placement, I've even had to carry an idea file. Have you come across that?
No.
Wow, that was us for my training like 25 or so years ago. We have it's like we have idea files. If you're stuck with ideas, you can just come up and look at this file. It's like, okay, what crafts can I be doing? What communication activity can I be doing? What so crafts, communication, what exercises can I be doing? It's an idea file. So this is a good tip for a lot of people. Maybe I'll talk about this in future podcasts or future episodes. So it's a book where you can write down. It's like idea files of the things that you can be dealing with patients. And I think what's important as well is you go in there not with the idea in your head, but also have a bag of little things, isn't it?
Yeah, I remember you showing me.
Yeah, you have a bag of goodies because you'll need that. You'll need that. But I digress. So you had a question, and I think I answered it. Was it helpful to have a student? Yes, it was, because the student was ready. The student was prepared. Well, when the student is prepared, the teacher shall arise. That's the belief in some Asian culture, not ancient culture. All right, and any more?
I suppose this might be a real question to put you on the spot, but what has been the hardest thing to teach? Like, what do you think is the hardest thing to teach?
The hardest thing to teach, it's more on the values, or more on the person like yourself learning to let go of structure. That is the most difficult thing to teach. A lot of people plan. A lot of people look forward to what's next. And I've always been not in an unsafe side. I always come in with a blank canvas, that I come in and let's see what we have. Let's see what the person has. Who is this person? Knowing the patient for the first time. It's teaching like yourself. You can do it, but I can't blame you for being a planner, isn't it? This is years of conditioning, isn't it? You've had to plan, but it's being a student, you've got to plan. I understand that. You see, even me trying to explain it is already difficult. But that, learning to submit to an empty canvas, isn't it?
So I know it's something we almost used a metaphor.
Yeah.
With my art background in painting, it's something that when I paint or draw, I never go in with a plan.
That's
I just
good.
work instinctively,
You see?
and that's always been the way I've worked. But I thought about this the last time I did a drawing, was actually that now I've been painting and drawing for 10, 15 years. I've now got a skills base to kind of get exactly what I want onto the canvas, and I can see what I need to do where, without it being, I don't plan what the picture's going to look like before I do it, but I have the skill to kind of facilitate that.
Whatever it is in your head.
No, even in my head, it's just, okay, so that I've done that over here, so therefore it needs something over here to respond to it. It's quite intuitive.
To balance out.
To balance it. It's kind of like hanging it all together.
Ah, I see.
And
Oh my God.
and that analogy was really helpful because actually I can see that that's what you're doing when you're
Yeah.
doing your assessments, because you're going in and you're using your skill and your knowledge base and your ability to sort of almost follow your nose
Yes.
and work out what the patient has or symptoms, or you're sort of recognizing a symptom and then assessing that symptom, and then okay, that's brought up this aspect, so we need to investigate that more, and you're kind of following the trail through,
Right.
which is exactly what I do when I paint.
Yes.
But the difference is at this point as a student, I don't have
The OT skills
the
here.
OT skills yet to be able to do that. So it's kind of the equivalent of when I was learning the skills of painting.
Ah.
And so I guess in painting, it doesn't matter if you get it wrong, you throw it away and it's
Yeah.
fine. But I suppose the thing is, obviously, you can't do that
No.
with patients. So what I guess the substitute is you prop yourself up with planning and you kind of use structure to ensure that so instead of sort of identifying symptoms sort of by investigation, you identify them by exclusion. And I think that's almost due to experience and just not having that skill yet.
Very
But
true.
the key word is yet.
Yes, very true.
And
Very
it was
true.
something I hadn't even considered before placement, is because all the OTs I'd come across used structure, because I think I've worked in an environment where that was kind of standard procedure.
It is. It's a protective thing, isn't it? It's a reassurance. Having the plan, knowing what to do, you're not going to be there left blank and not knowing what to do. That is, and I'm trying to put myself back many, many years ago when I was doing my placement. Again, my training is a little bit different. I already know how. I already know the how. So sometimes I go in, because our training was a bit different, all the foundation skills of medical foundation, neurological foundation, physical dysfunction, anatomy, kinesiology, everything was there. Physiology, it was all there already before we did the placement. So we have a very good foundation in that respect. And even when you're seeing one patient after another, it is not easy the first time. You're right. But yes, it really is important to have that skills. But I don't know how we can do that, because I think the process and the system in this country is you learn a part and then you do some placement and then you learn the other half of that part and then you apply that on another placement. Whereas when you go into placement, you have to do the entire thing where some parts are still missing, isn't it?
And I think that's the thing, is you then feel very out of your depth. And then I think it's been, this placement has been finding the line between where it's positive to take a risk, because not even a risk, but positive to try something I haven't done before, because actually that's where the growth is, but also not overstepping it too much and knocking my confidence.
Yeah.
And it's that kind of line.
Yeah.
And I think actually it's knowing where my skills level is at and not overdoing it, but also not being afraid to try.
Yeah. Self-awareness, isn't it? So just the right push, not to scare the student. And I would always encourage that anyway. You know, if you feel it's out of your depth, come back, step back, and let's look at it together. Because I know for a fact sometimes it just varies. There's no one set rule. There are some students that wanted to do it first alongside with their supervisor, and then they can do it afterwards. But then no two cases are ever the same. So in the end, you'll have the supervisor with you all the time, because every case is unique, isn't it? Wow. This is like a philosophical podcast now, isn't it? Do you have many more questions?
What's your ultimate vision, blue sky thinking for critical care OT? What would be your dream?
In other parts of the world, the skills are always there. It's not new in other countries. We would be seeing patients anywhere or within the scope of that continuum of the health, from being acute, apart from being in the surgery, isn't it? But as soon as person is stable or unstable, then an occupational therapist can come in, because we are addressing the performance component. What you guys are, a lot of people are missing It's not just performance areas, is ADL, work and leisure. That's out in the rehab area. But you also have performance components. And these performance components can be at risk, isn't it? They can be at risk when they are in having a critical condition. And the preventative treatment and intervention, these are all, it's doable. So from an occupational therapy perspective, there is a lot of scope in critical care. So my vision is that we will all be, imagine that, critical care is buzzing, with colors and with people wanting to sleep but being woken up to do some stuff. It's like, no, please get me to the ward. No, I am hoping, I know that it will happen in that respect, that OT, occupational therapy, will be perceived as one very essential part of the team, because we're not just dealing with the physical side of the patient. We are also dealing with the psychosocial and emotional side of the patient. And there's not a lot of psychologists in there in critical care. And occupational therapists can tap into this. So we're there, we're treating the person as a whole, looking at the person as a whole, and I wanted it. I know it will happen where we would be buzzing, we will be there, and then the consultants, the internists, intensivists, they would be saying, okay, well, this heart is stable, or this, the internal organs are unstable, there's no acidosis, but the person is still slow to recover. Okay, can you please, we need occupational therapy here, Imagine, it's like, if once a consultant says that, it's like, okay, well, this person just needs occupational therapy, meaning they want the person to engage, to wake up, to participate. Yeah. So yeah, lots of, it's not a big vision, but it's just there. We're there. Occupation is everywhere, guys. It's a skill for the art of living, isn't it? And when you're awake, when you're not doing exercise, you think of, okay, what am I going to do next? Isn't it? If you're at home on the weekend, you wake up, you've had your tea, you've had your toast. What am I going to do next? Sit down, I'll watch a TV. After that, what am I going to do next? It's the same in critical care.
It's almost incomprehensible to put yourself in someone's shoes in that environment, in that situation. The idea of being in the same room for weeks, months, and not really being able to do anything and having no autonomy and no real sort of say in what happens. Although, the medical teams are wonderful and a lot of the care they're receiving is life-saving and completely necessary, it also has a huge impact on that person, and OT is kind of a huge part in that, or can be a huge part in readdressing that sense of self.
It is because what happens and it's very standard as well, nowadays when somebody's ill, what's the natural tendency for the person to do? Rest and sleep, isn't it? That's it. Or once somebody gets the operation, what would you like to do? Not move and sleep. That's the natural tendency. You want to recover, yeah? But then science is changing now. We're acknowledging that the more you move, the quicker you recover. The longer you stay inactive, the more you would deteriorate. So you want to be active, you want to be involved. And it's not just mobility. Mobility is not just is the solution in there. Yes, you'll maintain your walking, gross motor skills, physical. But then we exercise so many things, isn't it? Wow. I'm in the path of self-realization and self-discovery here. This is good. All right. Yeah.
Okay, one final question.
Oh, there's a final question.
What's the one resource you wish you had? Like if you could stock up the cupboard with anything or have access to something, what would you have?
Really?
Yeah.
A resource, yeah?
So I know you talked a little bit about virtual reality.
Yeah.
Which sounded really interesting.
That's one of the things, but I wouldn't, that's one new thing to explore, really. But what is the resource? I mean, will a staff be a part of the resource?
I mean, it can be.
It can be,
You can
yeah.
stretch the definition.
If you want to start, it's like that is a resource that I would like to have more people that can help me help people. Yeah. Meaning more occupational therapists that can help us put all of these OT theories into practice. Try all of these theories that's out there that's been existing since the 60s and 70s and 80s. It's all been there, and it needed to be tried not just by me, not just by one person. That's why if I have to have a resource, wow, it would be great to have people coming over to try this, to try what I have been trying, so that they can say that it really works, isn't it? Because at the end of the day, if it's only me that's doing it, I'm just a crazy man, just doing all, not experimental stuff, but, all the occupation.
Emerging, yeah. Like that kind of
Yeah.
new ground.
Yeah. So that's the one resource that I would want. In terms of the physical, well, you said one, so that would be my one. But in terms of my concept about physical, like support and resources and equipment, I have no preference, because I think occupational therapists are there and should be equipped with creativity. There should be a lesson or a workshop on how to stimulate the right brain in university, how to be creative, like imagination, how to be a kid again. So we need to create more young people getting more the creative ones. And you know what's nice about having young people on board? Yeah, they're fearless. They don't care about the politics, isn't it?
Yeah.
They just go, this is what's nice about it, So yes, having staff or having a lot of people, having a lot of occupational therapists, that is one resource that we would need, guys. Okay. All right.
That's all my questions.
That's it. Oh, I don't want to end this conversation. This is really, really fun. This is OT Conversation, guys. So in this episode, once again, I am graced with the presence of Grace, who is an OT apprentice, and she has just completed her placement in critical care with me, and we've had lots of fun conversations. I hope I can invite you again on future OT Conversations.
Yeah, sure.
Yeah, okay, good. Yeah, we'll talk about that after outside the studio. Okay, guys, again, thank you so much. I hope you have learned a little something from this episode. My recommendation is you go and talk to one another, have that discussion, have that conversation. And if you've learned something, pass this information or pass this podcast around, or give the information to others. Learn together, grow together. Just remember, anything you do matters and has an outcome. Until next time, bye!